Okay, good morning, everybody. Welcome to our first webinar on COPD. A few things first, all your phones or your microphones are muted so that there will be no interference happening during the presentation. There is a question box in there. If you want to ask questions, just type it down and and if we have time, we will ask Dr. Johnson these questions. And if not, we will ask him to respond to your questions and we'll send it out to you later. So let us begin. Our first speaker, or our speaker, is Dr. John Sin, who is the director of the Center for Heart and Lung Innovation and interim vice president of research at Providence Healthcare and a professor of medicine at the University of British Columbia in Vancouver, Canada. He holds a Tier 1 Canada Research Chair in chronic obstructive pulmonary disease and the Lazzari Family Chair at HLI. He has published 450 plus papers in COPD and has an Edge index of 83. He is currently the section editor of COPD for the European Respiratory Care and the Attorney Journal and an associate editor of the Canadian Journal of Respiratory, Critical Care, and Sleep Medicine. He is also a special advisor to BMJ and sits on editorial boards of the American Journal of Respiratory and Critical Care Medicine, Thorax, and Chest. He has been a member of the Scientific Committee of GOLD, which is Global Initiative for Chronic Obstructive Lung Disease, since 2009. His research focus is using omics data to discover novel biomarkers of disease activity and new therapeutic targets to reduce hospitalizations and mortality in patients with COPD. Let's welcome Dr. Don Sim.
Thank you, Min. If you can't hear me, just let me know. And my presentation isn't that long, so I think we'll have quite a bit of time for question and hopefully some answers. So I was asked to give an overview of COPD care in 2018 and beyond, and that's what I intend to do. So I hope you can see my slides. If not, again, let me know and I'll try to manipulate some things here. So as many of you on the call know, that COPD is a large burden in Canada. It's one of the most highly prevalent chronic lung disease in Canada and elsewhere, affecting about 2.6 million Canadians, and globally well over 300 million people. And many of patients with COPD remain undiagnosed. So it's a silent disease in many settings. COPD is the leading driver of hospitalization in pretty much every province throughout Canada. And not surprisingly, that would not only increase morbidity, but also the costs associated with COPD care. And in fact, 60% of the direct costs of COPD are driven by hospitalization, hospital-based care. So this is a major public health problem in Canada. And globally as well. In 2016, COPD was the 9th leading cause of death throughout the world, and you can see on this slide how the top 10 list ranks out. Now, worldwide, there's about 3 million COPD deaths per year, and this slide just shows you that COPD accounts for about 6% of all the death accounted for in 2017. And the other major causes of death are shown in bubbles. The size of the bubble represents the percentage of total mortality. Well, if we have a crystal ball and projected what would happen over the next 20 years or so, we would see something like this, that currently COPD is the 9th leading cause of global mortality. But by 2040, that the number of deaths will increase such that COPD will be ranked 4th leading cause of mortality, trailing only ischemic heart disease, stroke, and pneumonia. And that's because you can see that most major causes of death over the next 20 years or so will decline. And the notable exception, unfortunately, is COPD. In fact, if you look at this publication from Foreman, who represents the Global Burden of Disease initiative, and if you read their document, it will say something like this, and I lifted directly from that document in Lancet. While the leading three causes of mortality in 2016 remain the same in 2040, most of the top 10 causes fell in rank by 2040. That's their crystal ball, their best projection. The primary exception was COPD, which was forecasted to rise from ninth to fourth leading cause of death between 2016 and 2040. So, despite the declining rates of smoking, certainly in Canada and most Western countries, COPD morbidity and mortality will continue to rise over the next 20 to 30 years. So that's the backdrop. At a patient level, what are the most important aspects of COPD care? Well, most patients don't want to experience exacerbations. They don't want to go into emergency rooms. They don't want to go into hospitals because they can't breathe. And we call this exacerbation. So they want, ideally, a life free of exacerbations of their COPD. Now, the way we diagnose and classify severity of COPD is based on lung function. The most common metric is this metric called FEV1, forced expiratory volume in 1 second. And generally, most patients have an FEV1 less than 80%. So in other words, their lung function is 80% or less when they have COPD. And when that happens, and they're symptomatic, the first line of therapy is a long-acting muscarinic antagonist, or LAMA. These are drugs that target airway smooth muscles and induce bronchodilation or opening up of the airways, and thus improving FEV1. These are data from China, but was published in New England Journal of Medicine last year, where they compared the effect of a LAMA, in this case tiotropium, which is the most commonly used LAMA in Canada, against placebo. And on the y-axis plots patients with exacerbation. The higher the number, the worse off patients are. And over a 24-month period, and that's the x-axis, you can see that the placebo arm depicted in gray is higher than the tiotropium arm. So this was a randomized controlled trial where one half of the patients received placebo and the other half received tiotropium. And those who were on tiotropium had fewer exacerbations by a factor of 40%. So hazard ratio, the inverse, is what I'm talking about. So about 40% relative risk reduction in exacerbation with tiotropium, even though they had relatively mild COPD as defined by FEV1 of 73% of predicted. And the number needed to treat. So this is the metric that I think most clinicians care about. How many patients do you need to treat for 2 years to prevent an exacerbation? And it turns out to be about 8 to 10 patients. So this is actually a very good number. Most of the therapies that we use in COPD and other conditions have a number needed to treat of 20 or 15 or even 30. So 8 to 10 is a very good number, very cost-effective number, and you can see that those who are treated with tiotropium on average had fewer exacerbations. So here is just a depiction or illustration of the various long-acting muscarinic antagonists, or LAMAs, that are available in Canada. There may be more, but these are the most common ones, with one notable exception. So the exception is C. So that is not a long-acting muscarinic antagonist. That's actually a combination of short-acting muscarinic antagonist and a short-acting beta-2 adrenergic agent. It's called Combivent. And this C is generally used as an acute reliever rather than as maintenance therapy. So the other ones are either once a day or twice daily preparations, and they fall into this category of long-acting muscarinic antagonist. And they should be the first-line agent for most patients with COPD. So assuming that patients are on first-line therapy with LAMA and they continue to experience symptoms and or exacerbation, what will be the second line of treatment? So our goal is to make patients relatively free of exacerbations. Well, the answer is not straightforward because it depends on whether the patient just has COPD or they have a combination of COPD and asthma. So asthma is fairly common in the general population, maybe 5% or higher. And it's conceivable that patients can have both asthma and COPD. So if they have just COPD, I think the consensus is that the second line therapy should be a dual bronchodilator consisting of a LAMA that we discussed and a LABA, which stands for long-acting beta-2 adrenergic agonist. And they are different types of drugs, usually found in one inhaler, and they both target airway smooth muscles, inducing relaxation and improvements in FEV1. So this was a very important study that compared inhaled corticosteroid long-acting beta-2 agonist combination against the dual bronchodilator, LABA and LAMA, in one inhaler over 1 year. And they looked at, among other things, exacerbations per individual per year. And that's plotted on the y-axis. And on average, those who were assigned to a LABA-LAMA combination had lower frequency of exacerbation by almost 20% compared to ICS-LABA combination. So if they just have COPD and not asthma, concomitant asthma, then the recommendation as a second-line agent is a LABA-LAMA combination to induce greater bronchodilation. And we have, several fixed dose combinations. Of course, one can use non-fixed. You can use LABA and LAMA as separate inhalers, and that would be okay too. Alternatively, one can prescribe just one type of inhaler that contains both, and these are the ones that are available in Canada. And some are twice daily, and some are once daily. And some are dry powders, and some are aerosol. Excuse me. As mentioned, some patients may have both asthma and COPD. And some call this asthma-COPD overlap or asthma-COPD overlap syndrome, or ACOS for short. The nomenclature is continuing to evolve in this area. And this cartoon depicts what we think is happening in this condition. So we think that some individuals develop or are born with asthma, and this may begin in childhood, and in many cases it develops in childhood or even at birth. And the airways are characterized by what we call type 2 inflammation, characterized by increase in eosinophils, mast cells, high IgE levels, lots of mucus in the form of goblet cells, and the smooth muscle depicted in this pink becomes thickened and and displaying increased contractility. And then there are lymphocytes that are Th2 dominant. So this is how they would start off. And over the years, they may take up smoking, or they're exposed to a lot of air pollution or biomass or even marijuana smoke, a lot of irritants that shift the inflammatory response from an asthmatic phenotype to a more of a COPD phenotype characterized by different cytokines and different markers of inflammatory and oxidative stress. And that induces COPD-like changes in the airway characterized by similar things as asthma, but now we have also emphysema around the airways, causing gas exchange problems. And so these so-called ACOS patients or asthma COPD patients have a different set of molecular profiling of their airways. So there are individuals in the community with both asthma and COPD. It's hard to estimate exactly how many, and I'll show you some data from other studies that have tried to characterize this. So clinically, how can we diagnose the asthma COPD patients? Now, there's lots of controversy about this. What we have proposed a couple of years ago are the following: that they have to have what we call persistent airflow limitation, that they have decreases in their FEU1 FVC ratio. That is not fully reversible with bronchodilation. That they have some sort of exposure history. So whether it's cigarette smoke or biomass, or perhaps in 10 to 20 years, we'll say marijuana smoke or e-cigarettes, some sort of irritant exposure history is required. And then a documented history of asthma before age 40. And this is because many of these so-called asthma COPD overlap patients develop or demonstrated asthma in childhood. Now, there will be individuals who develop asthma later in life, in which case we would accept a bronchodilatory response following Ventolin or salbutamol of 400 mLs or more as equivalent to a documented history of asthma before age 40. So we think that these three attributes or traits are required to make a diagnosis of asthma COPD overlap syndrome. Now, this can be complemented with some additional information. One is a history of atopy or allergic rhinitis, or a bronchodilatory response of 200 mLs and 12% from baseline. And perhaps most importantly, taking a CBC or complete blood count and demonstrating eosinophil count of greater than 300 cells per microliter. In British Columbia, eosinophils are expressed as cells per liter, so this would translate to 0.3 times 10 to the 6th. So how common is the asthma COPD phenotype, and what's the relevance in terms of exacerbation rate? Spiromics is a US-based cohort, and they've just recently published some information on this category of patients. Now, the x-axis plots individuals who are what we call controls, never smoker controls, with and then followed by smokers. They're active smokers with no symptoms or minimal symptoms. This is COPD assessment tool. This is a questionnaire that we can use to determine whether patients are symptomatic or relatively asymptomatic. A score of less than 10 would indicate minimal or no symptoms. There are smokers who don't have COPD but have significant symptoms, a CAT score of 10 or more. And then there are those with COPD as defined by spirometry, FEU1 FVC ratio of less than 70%, but relatively no symptoms. And then there are COPD patients with significant symptoms. And when spiromics investigators looked at this, in the general population of never smokers, average age 50 to 60, about 2% have a childhood history of asthma. In smokers with relatively no symptoms but no COPD, about 4% have history of childhood asthma. And then the next category, about 10%. And then once you get into COPD, 8 to 11%, depending on whether they have symptoms or not. So you can see a significant rise in the prevalence of history of childhood asthma, particularly in those with symptoms. So we think that anywhere between 10 to 20% of patients with COPD who present to clinics have an overlap of asthma and COPD. But what's the relevance of this? When they looked at exacerbations per year, you can see that the category that has the highest rate of exacerbation, about 50% over 1 year, are those with COPD and a CAT score of 10 or greater, so symptomatic COPD patients. And they're the ones who have the highest prevalence of asthma. So having asthma and COPD is more likely to cause exacerbation than just having COPD alone. And this has been demonstrated in many other studies. So we don't have strong evidence for this, but common sense would dictate that if you have both COPD and asthma, it may be better to use an ICS long-acting beta-2 agonist inhalers. ICS standing for inhaled corticosteroids. Now, there would need to be additional studies to validate this, but right now I think most people would agree that this would be a reasonable course. Of course, ICS and LABA can be used as separate inhalers, or they can be prescribed as a fixed dose inhaler, and I've listed a few, and there are many coming down the pipeline. What if, as a clinician, you're not sure if they've had asthma and the patient can't remember whether they had asthma as a child? Well, one thing to measure, as noted before, are these things. These are eosinophils in blood. And that's a simple CBC with differential. That is really done ubiquitously in the province of British Columbia. Almost everyone has had a CBC and a differential done, complete blood count. And there, the elevation of blood eosinophils are related to responsiveness of that individual to inhaled corticosteroids. So this is an interesting study. It's a busy slide, so let me walk you through that. So y-axis plots COPD exacerbation rate per patient over 1 year. The higher means the increased or more exacerbation per patient. And then there are two groups. One is denoted in blue. This is the ICS-LABA group. They use the beclomethasone and formoterol combination, but it's an ICS-LABA combination. The orange depicts individuals who are assigned, COPD patients who are assigned only long-acting beta-2 agonists, so no inhaled corticosteroids were provided. And then the x-axis is the comparison between the ICS-LABA group and LABA according to patients' eosinophil count in their peripheral blood. So the first category is eosinophils from 0 to less than 110 cells per microliter. The second category is 110 to 182, and so on. And then the last category are the ones with increased eosinophils in their blood, 280 cells per microliter or more. And you can see the separation between the orange bar and the blue bar gets progressively greater as the eosinophil count in the patients increase, such that in the last group, the reduction in exacerbation is almost 50% in favor of those who were treated with blue, which is ICS-LABA. So the effect of ICS-LABA, or having ICS, inhaled corticosteroids, is amplified in those who have high eosinophils. This can be depicted in a slightly different way, but I think a very meaningful way on this graph. Annual exacerbation rate is plotted on the y-axis, and eosinophil counts are plotted on the x-axis as 10 to the minus cells per liter. This is how, in British Columbia, eosinophil counts are read out by Life Labs and others. So the blue bar represents individuals who are treated only with a long-acting beta-2 agonist, in this case formoterol, and then the purple bar represents those who were treated with inhaled corticosteroids, long-acting beta-2 agonist combination. And you can see the separation in the curve gets exaggerated as the patient's eosinophil count increases, meaning that the effect of ICS is the strongest when patients have high eosinophil count. Well, where is that inflection point? And that is shown in the graph on the lower bottom, where you can see this line, which shows the difference in the effect between ICS-LABA and LABA alone, and the line flattens out around 0.3, somewhere between 0.2 and 0.4. It's around 0.3 or 300 cells per microliter. So this is where the 300 cells per microliter value came from. So on the right-hand side, I've just shown you what our interpretation is. If a patient has blood eosinophil count less than 100 cells per microliter, we probably should not give ICS. If their blood eosinophil count is 300 or greater, consider inhaled corticosteroids. If it falls somewhere between 100 to 300, then there's equipoise. There's uncertainty about whether to give ICS or not. So I hope that's fairly clear in terms of the second line therapy. So if they have asthma or high eosinophils, treat them with ICS-LABA. If they don't have those characteristics, then give them inhaled, then the dual bronchodilator in the form of LABA-LAMA therapy. Now, assuming that they're on second line therapy and the patients are still symptomatic and having recurrent exacerbations, what will be the third line treatment for COPD? Well, we would suggest adding all of the various components of inhalers together, LABA, LAMA, and inhaled corticosteroids, to induce bronchodilation and to have an anti-inflammatory effect. So there have been several, I think, pivotal studies in this field over the last couple of years. Here's one that was published earlier on this year, where the investigators compared the so-called triple therapy, beclomethasone, formoterol, and glycopyrroniate, which is ICS-LABA-LAMA combination, against the dual bronchodilator, LABA-LAMA combination, over a 1-year period in COPD patients. So this is a busy slide, but let me just focus you on the rate of exacerbation over 1 year on the y-axis on just the first two bars, where they compare moderate to severe exacerbation between the triple therapy denoted by blue and dual bronchodilator therapy denoted by orange. And you can see that on average, those who were on triple therapy had fewer exacerbation, 0.5 versus 0.59 on those who were on dual bronchodilator. This was confirmed in a much larger study that was published earlier on in New England Journal of Medicine, where they compared triple therapy, denoted by green line, against ICS-LABA, denoted by orange line, and LABA-LAMA combination, denoted by the blue line. And on the y-axis is plotted patients who had an exacerbation over 1 year period, and x-axis shows you the days since randomization, going from 0 days at that beginning of the trial to 364 days end of the trial. So 1 year study. The lower the curve, the better. So on average, those who were on the green line, which denotes triple therapy, did better than the orange line or the blue line on average. But there was a cost to that improvement in exacerbation rate, which was pneumonia risk. So those who were on triple therapy containing ICS-LABA-LAMA, their pneumonia risk over this 1 year period was 8% compared to 7% in the ICS-LABA and 5% in the LABA-LAMA combination. So clearly it's the ICS, inhaled corticosteroids, that are driving up the pneumonia risk, and that's denoted here in the bar graphs. So how do we balance the exacerbation benefits with the increase in pneumonia risk? And it's hard to do. And this is another study that shows this. So on average, triple therapy, denoted by the middle bar, is better than dual therapy with ICS-LAMA or even monotherapy with tiotropium, and there's a 20% decrease. And the number of patients that need to be treated with triple therapy to prevent one patient from exacerbating over 1 year would be about 25, and number needed to harm causing one pneumonia would be 20 patients. So you can see that there is almost a balanced trade-off between reducing exacerbation and possibly inducing pneumonia. So I think blindly giving triple therapy to patients is probably not a good way of treating patients. Again, the use of eosinophils may be helpful in guiding ICS therapy, whether it's in triple therapy or dual therapy in the form of the orange line that's provided here. On the y-axis is again plotted the annual exacerbation rate. The lower the better. And I've segregated the data between those who had eosinophil counts less than 150 in their peripheral blood against those with eosinophils greater than 150. In the previous slides, we stated, or I stated, that 300 is the magical level. Unfortunately, in Lipson's study, 300 was not, at least that data was not provided. But you can see there's a trend in those whose eosinophils are greater or equal to 150 of the so-called triple therapy having a much better response compared to LABA-LAMA therapy than in those with eosinophil counts less than 150. So reinforcing the notion that serum or blood eosinophils could be an important biomarker in guiding ICS therapy, whether it's in triple or in dual form. So here's our take of how COPD patients could be treated, or maybe should be treated going forward. If they're symptomatic with a CAT score of 10 or greater and experiencing exacerbation, let's say greater than one exacerbation per year, we believe that the next thing to figure out is whether they have an asthma component, and that can be just based on history of childhood asthma, or a blood eosinophil count on CBC of 300 or more, in which case we would recommend that they go on an ICS containing dual therapy, whether it's ICS long-acting muscarinic antagonist combination or ICS long-acting beta-2 agonist combination. We do not advocate ICS alone. I think there are plenty of studies showing that that's not very effective in COPD. If that's insufficient, the second-line therapy would be triple therapy in the form of ICS, LAMA, LABA therapy, and that can be done in one inhaler or multiple inhalers. If, on the other hand, patient gives no indication of asthma through history or blood eosinophil count, then we would recommend either LAMA as the monotherapy or LABA-LAMA therapy as dual bronchodilator therapy. We do not see much value in adding ICS in this setting. So that's the present. Where are we going in terms of the future? Well, we know that the biggest driver of COPD hospitalizations are exacerbations. And exacerbations are largely caused by infections, usually viral infections, but they can also be bacterial. So in this study done by my postdoc, we measured immunoglobulin levels in the form of IgG in blood of COPD patients, and we related to their risk of exacerbations and hospitalization. And this is a simple blood measurement to see whether you have enough immunoglobulins in your body to protect you against exacerbation and respiratory infections. What we found, and this was a very interesting observation, When we measured the total IgG levels, denoted in the x-axis, so less than 7 would indicate immunodeficiency, and anything above 7 would be normal. We found that about 20 to 25% of patients who have recurrent exacerbations have levels less than 7 grams per liter, indicating immunodeficiency. The expected rate is less than 5%. So COPD patients who recurrently exacerbate have a higher prevalence or higher risk of having immunodeficiency. And what we found is if they're immunodeficient, their risk of exacerbation is almost double the risk found in those with normal IgG levels, denoted by the yellow bars. And that also is true for COPD hospitalization. So we plotted the patients with hospitalizations on the y-axis and follow-up in months. And the blue bar indicates immunodeficiency. And those who are immunodeficient are far more likely to experience hospitalization. In fact, 30% risk of hospitalization by 12 months than those with normal IgG levels, denoted by green, orange, or red, as shown here. They only have about 15% risk of hospitalization over a 12-month period, so almost doubling of the risk of hospitalization. And this is important because there are therapies to increase IgG levels in blood to protect patients against infections. So this is showing the impact of IgG deficiency, denoted by red bar denoted by the blue bar, and against the normal IgG people, denoted by red. And you can see the rate of exacerbation per person year is significantly higher if patients are immunodeficient. So we wouldn't recommend this for all patients because IgG replacement therapy is extremely expensive, around $40,000 to $50,000 per year. So we would only recommend it if patients are on triple therapy or maximal inhaler therapy and continue to exacerbate year after year. There's another therapy that can be given to reduce the risk of exacerbation, and this is long-term antibiotic therapy in the form of azithromycin on a daily basis. So this study pointed out, I think, on an important feature of COPD patients that had not been previously thought about. And this is the whole importance of Helicobacter, having Helicobacter pylori in the stomach of COPD patients. So in addition to causing gastritis and ulcerations and even gastric cancer with Helicobacter, chronic Helicobacter infection, the presence of Helicobacter in the stomach makes the immune response very different in the COPD lung, and that increases the risk of exacerbation. And azithromycin reduces that risk. And so this is a busy slide. Let me just walk you through it. This is proportion free of COPD exacerbation. So ideally, you want the bar to be at 1. So higher the bar, the better. The lower the bar, the worse. So this is a very busy slide, but just focus on the blue and the red. So the blue lines represent individuals who were on placebo, and the red represents those who were on azithromycin over 1 year. And you can see the red bar, particularly the solid red bar, is higher than the blue bar, indicating that azithromycin is highly effective in preventing exacerbation on top of all the inhalers. But there's a difference between the solid red bar and the dotted red bar. In fact, the solid red bar is far better than the dotted red bar. And the dotted represents those who were Helicobacter negative, and the red bar indicated Helicobacter positive individuals. So azithromycin tends to be more effective if you have Helicobacter in your stomach, and that's because we think azithromycin is partially effective in suppressing Helicobacter as an antibiotic. Now, it's important to note that we're not advocating treating Helicobacter as azithromycin. What we are advocating is that if patients are having recurrent exacerbation, to do a simple blood test for Helicobacter or a breath test for Helicobacter. And if Helicobacter is present, to treat the Helicobacter effectively. And that may in itself reduce exacerbation rate going forward. And certainly before putting patients on long-term antibiotic therapy, check the Helicobacter pylori status and treat it before initiating. So what's the future? And this, I promise, is the penultimate slide. COPD is a very heterogeneous condition. Some patients have lots of exacerbations. Some people do not. Some people have lots of symptoms. Some people do not. And there are different now ways of trying to identify what therapies we need to give to enhance the efficacy of drugs and to reduce the harm of the drugs. And some of it is blood tests, some of it is CT scans, some of it is pulse oximetry, and some and other tests that are not even listed here. And so we can segregate patients based on what's driving their COPD. As I've shown that some people have this IgG deficiency that is probably responsible for their recurrent exacerbation, in which case replacement therapy with IgG may be a condition, may be plausible. And some patients, they have high blood eosinophils, in which case, we may want to give them more ICS, inhaled corticosteroids. Some people have low blood eosinophils, in which case we want to give them, bronchodilators and maybe more bronchodilators, and so on. So we now have some, I think, very good tools to segregate patients based on what's driving their COPD and give more targeted therapy. We call this precision medicine, more targeted therapy, so it's right for the patient and not just right at one point in time, but right all the time. So this is my final slide, just summarizing, what I've mentioned about, bronchodilators and inhaled corticosteroids. And with that, I will stop and entertain any questions.
Thank you, Don. That was really great. Just to let you know, we will unmute your microphones or your phone so you could directly ask your questions if you have any. You can speak on your phone, or you could speak on the Are there any questions from the audience? Okay, let me begin with some of the questions. With all these new medications or combinations of medications, are they accessible to all patients with COPD?
So, I think it's important to note that we need to carefully take patients' history and do what we call phenotyping to ensure that the right patients are being dispensed to the right patient, right medications are being dispensed to the right patient. So the short answer is no. I mean, not every drug is right for every COPD patient. We must do a better job of, identifying patients who would respond to certain drugs and not to others.
Mm-hmm. And what advice can you give people in order to avoid or prevent exacerbations?
So obviously, take your inhalers as prescribed and make sure that you're taking the right inhaler. What I didn't talk about are some of the, things that you can do outside of drugs, which are, regular exercise, rehab, there are formalized rehab programs out there, eating right, lots of antioxidants, green things rather than meat, and getting, vaccination with, we're now entering into the flu season. So, making sure that your vaccinations are all up to date, including for influenza and for pneumonia, pneumococcal pneumonia. So these are things that I think all COPD patients can do to protect themselves against serious exacerbation.
Ken?
Dr.
Okay, go ahead.
I just wondered if I was a patient who did not respond to just the bronchodilators and I need the ICS, am I to assume I have high eosinophils?
Well, that can be checked. That's a simple blood test. I don't think any assumption should be made. It may be that you have asthma, and that you've never known about.
Well,
so
actually, I was diagnosed not with asthma, but I'm wondering now if maybe that was incorrect.
Yeah, that may well be correct. Asthma and COPD are hard to diagnose. Sorry, I didn't hear you.
Is a routine check, Dr. Sin?
Yes, the blood eosinophils are very, very routine. It's about $10 at Life Labs, yeah, and should be checked before you go on lifelong, ICS therapy, for sure.
Mm-hmm. Thank you.
Any other questions? If not, we'd like to thank Dr. Johnson for sharing his time and his expertise with us today. Thank you very much. And just to remind you, this will be recorded. And for those people who were not able to access this webinar right now, can access the slides or the recording on our website, and we will let you know when it's ready out there. Thank you so much.